This is the Functional Rehab Podcast with your host, Dr. Ashley Mack.
In the world of rehabilitative medicine, there are a ton of professionals. You probably heard of physical therapists and occupational therapists, but one of the professions that might not necessarily get the credit it actually deserves are speech and language pathologists. And so I thought it would be a great opportunity to take today's episode and shed some light on what these awesome professionals do, but also the work that they can provide for yourself or your family members, especially in the senior living environment. So today I have Kathie-Lee Petsch, who is an SLP. We're going to talk a little bit more about the profession. Kathie-Lee, it's so great seeing you. Thank you for being a guest on today's episode.
Yeah, of course. Thanks for having me. I'm so excited. I've never been on a podcast before, so this is new, but I'm looking forward to just informing the masses about what we do and why we do what we do.
Yeah, and I think, there's a lot of you around, but because you're in such a specialized setting, it is a little more challenging to actually understand what your team does. And so before we go into what SLP is, tell us a little bit more about yourself.
So I've been a speech therapist now for about 2 years. I graduated May 2022 with my master's. You do need a master's degree to be a speech language pathologist. So it's about 6 years of schooling. For me, it was 7. I was actually pre-med. My undergrad degree is in biochemistry, but just wasn't really feeling the whole next 10 years of my life being in medical school. So I wanted something that was still in healthcare. And so I actually, funny enough, was watching The Bachelor, and there was a contestant on there. She was a speech therapist, and I had a good friend of mine that was also going into school for the same thing. Spoke to her about it, and here we are. So I'm currently located in Cape Coral, Florida, and I work at a skilled nursing facility that's within a retirement community.
Very cool journey to be able to see, hey, I want to go down this track, but then noticing that, yeah, you probably don't want to go through that much schooling, but still want to be involved in healthcare and then being able to ask around. I think it's huge. My first job was actually at a senior living facility that had a memory care unit, but then ours was considered an outpatient clinic. So we actually saw about 75% of my caseload was actually the residents, but then the other 25% was people like you and me who are dealing with some aches and pains. So let's take a deep dive into your role as an SLP, because I remember my initial thoughts, and I think I learned about speech therapy even when I was in high school, because some of my classmates or like people I knew actually had to go to speech, and I didn't know what that was. And then I guess like the movie The King's Speech came out, and I was like, oh, a speech therapist, like how people with stutters. It's a very large and vast profession, kind of like what physical therapy is. So tell us a little bit more about what a speech and language pathologist is and does.
Yeah, sure. So it's a whole lot, to be honest, a lot more than people think. I do get the question when I walk into a patient's room, my speech is fine. Or some people will like pretend to slur their speech just for kicks and giggles, but really to get into it. So we're a medically aligned field. I did pull up a little visual because I sometimes even forget everything that we do. So we work with populations that are premature and full-term infants. We work with children, adolescents, adults, and geriatrics. I'm more so the geriatric population. So we target developmental disorders, genetic disorders, stroke and brain injury. We deal with progressive neurological disorders. So that's like your ALS, your Parkinson's, your dementia. We work with cognitive communication disorders. So that could be really anything to do with literacy, stuff like that. You work with patients for hearing impairments through oral rehabilitation, feeding disorders. That could be for infants particularly. Sometimes some kids are born with cleft palate, and so they need that intervention with the speech therapist in order to improve their nutrition status. You don't want a malnourished baby. They're just so sensitive and fragile in that young part of their life. Fluency, motor speech disorders, social communication, augmentative and alternative communication, speech sound disorders, expressive and receptive language disorders. I'm sure people have heard about Bruce Willis and his aphasia. We would be someone that would help him with that. Voice disorders, Parkinson's patients that start to speak very softly, or you have your vocal folds that have now become impaired or paralyzed or weaker. We help with strengthening that. And then, of course, my favorite, dysphagia, the swallowing disorders, which we tend to see in patients, typically those that have had traumatic brain injuries we can look at. People that have had strokes is one of the main things that everyone goes to whenever they think about swallowing disorders. Or it could just be a decline in function with dementia over time. Unfortunately, your swallowing abilities do tend to get a little weaker. So that's all the stuff that we do. And we can work in schools, we can work in skilled nursing facilities, which is where I'm at, private practices, hospitals, and the NICU, again, for the preemies and infants that are having those feeding problems, and then acute care. And that's it.
That is it's such a vast profession. And I really appreciate you sharing that with us and the listeners. I think it's important to understand that even though it's like speech and language, eating and feeding is actually a very large, very important piece to it, because, and I'll say over my years as a physical therapist, ever since 2012, I've come across scenarios where the patient themselves have dysphagia, and they have trouble eating, feeding, swallowing, and all that stuff. And so as a result, they're actually placed on very specific textural and consistency diets to ensure that they don't aspirate, right? So let's talk a little bit more about that, because it's such a crucial part. I know that there's many different ways to communicate, and I'm very thankful for the job that you do, but something as simple as biting into an apple and swallowing it, ensuring that you are not going to choke or even worse, aspirate, right? So let's talk a little bit more about feeding itself. Like, what are some things to consider? And if you can, we can go a little bit more in depth in regards to like why it is so important, in regards to the aspiration and all that other stuff. Sure.
Yeah. So one of the main things when it comes to textures, it has to do with patients' level of alertness, their ability to even be rehabilitated, depending on what their cognitive status is at the time. So what I see a lot in hospitals when I do get a patient that comes in is they will be on an altered diet, but sometimes there's really no rhyme or reason as to why it happened. Sometimes they didn't even see a speech therapist, but their diet was altered. And it could be that when the patient was in the hospital, they were just not in an alert level that really allowed for them to be able to chew the food properly, sit up properly, and make sure they're swallowing and taking small bites. Sometimes after traumatic brain injuries, patients tend to have really impulsive behaviors. Unfortunately, they might just shove the whole thing in their mouth, try to swallow it, and choke on it. So there's that. You have your stroke victims, unfortunately, where different neurons and different nerves have been damaged. So those nerves that are connected to your ability to swallow, those have been affected, and so they're weaker, and so they can't really swallow. And sometimes you got to work on strengthening the pharyngeal muscles and all that stuff, because you got the pharyngeal stripping wave. If you go into the modified beer and swallow study and the 17 components that it does go over, there's just so much to the swallow from the moment you put food into your mouth until it hits your stomach. We look at all of that. So when it comes to diets and textures, I put them into three main categories, or well, four really. So there's pureed, there's mechanical soft. So I say mechanical soft is anything, if you can smush it between your thumb and your index finger, that's soft enough for anyone to really chew. You have your chopped diet. Really, that's when things are just chopped up for you. That's more so for people that have trouble chewing. They just don't have the range of motion oral motor wise in their mouth to really manipulate the food into a nice solid form bolus, which is what we call it. And then you have your regular diet, which is me going out to Five Guys and getting a cheeseburger. So that's the different textures. And then you also have your liquids. So there's thin, which is the liquids we drink every single day. That's your milk, your water, your juice. Nothing's been manipulated. You have your nectar thick liquids. I like to say that this is more so closely to smoothie texture. So like the naked smoothies, those are my favorite. I love orange mango. And that's what I really compare it to. And then you have honey thick. that stuff is really thick, man. You really got to tilt the cup and let gravity do its work to get it in. But the reason that thickened liquids do happen is because thin liquids, they're so fast. And when you look at the anatomy, your throat is actually in front of your esophagus. So things might just want to sneak down the front before they can really get to the back. So we put people on thickened liquids sometimes because it allows them to learn to manipulate the liquids better and make sure it goes down the right way because it goes down slower. Now, I am all for thickened liquids in the right scenario. However, when a patient is silently aspirating, you do run the risk that thickened liquids, because they have these different chemicals and stuff in it, if that gets into your lungs, that's not really that safe. And it can cause aspiration pneumonia to occur because bacteria would love to thrive in all this thick, gunky stuff that's now in your lungs. So thin liquids sometimes, while yes, they may be a worst enemy, sometimes it's safer than thick liquids, because if that just a little bit goes into your lungs, that can evaporate. But if it's a really big amount, then we have problems. But just wanted to shed light on that because I don't always like to recommend thickened liquids unless absolutely necessary, because when we are looking at patients and treating them as a whole, we have to look at their quality of life. You know, I have patients that are in their 90s. I have patients that are 99 and 100. They don't want to be on an altered diet. They're at a point where, you know, they want to just enjoy food. They want to eat what they want to eat. They've lived a full life. So when we do treat patients, we also have to look at them as a whole. It can't just be, oh, well, they cough when they eat food, or they choke a little bit, or maybe if they drink some liquid, they cough like once or twice. In the grand scheme of things, is the patient actually satisfied? Are they meeting their nutrition needs and all that type of stuff? So that's really the whole scope of how we look at patients as far as swallowing and textures and liquids and all that.
And is this something where you're in collaboration with the RD, or say if since you're working at a facility, is this something where you're communicating with food services to ensure that, you know, the recommendations are followed? Or tell us a little more about that.
Yes, absolutely. It definitely is a collaboration effort. So I go in there texture wise and figure out what's the best texture for that patient. And then I will be collaborating with the unit manager, with the patient's family. Sometimes these patients lack capacity, especially where I work at. There's not a lot of patients where I work that actually have capacity to make their own healthcare decisions. So they have their healthcare surrogate. You're talking to the dietitian, and you're going to collaborate with the kitchen staff to make sure that they're following through, because sometimes you couldn't order that morning. Unfortunately, meal tickets were printed the night before, so you have to go down to the dietary staff office and talk to them and be like, hey, I just downgraded or upgraded this patient to this. Please change the diet. So there always is collaboration going on, but they love receiving emails from me because sometimes it validates them, because sometimes, you know, the nursing staff or the dietitian, they think this would be a good diet, but they're not the professional on it. So it's really nice to see when everyone comes together and we're all in agreement with something and the patient's just at their best. So, yeah.
All right. Very, very cool. So it seems as if one of your big pieces is the mechanical components of feeding. So it's like the textures and everything like that. Let's talk about pneumonia, right? And aspiration specifically, right? Because I know that it's a big thing to consider. We want to make sure that no patients are choking, obviously to block off the airways, but then the second part is actually the aspiration itself. So can you share with the audience a little bit more about what aspiration is and why it is such a event that we need to be very cautious of during a patient's recovery?
Absolutely. So aspiration is when food or liquid, anything, goes below your vocal folds and into your lungs. So there's something called penetration. That's when it just sits on top of the vocal folds. But aspiration is when it goes below the vocal folds and into your lungs. And the reason that aspiration pneumonia happens is actually because it's a 3-pillar type thing. So the reason that we might have aspiration pneumonia is 1, you already have pneumonia. 2, you have poor immune health. 3, you have poor oral care. So something that people don't realize is that people that are at risk for aspiration or aspiration pneumonia actually need to be brushing their teeth on a regular basis. all that food that gets stuck in a patient's mouth, that harbors bacteria. If you're aspirating on that, that gets into your lungs, that's no good. So if you're already aspirating, if your oral care is not good, you have poor immune system, and you already are at risk for pneumonia, all of those things combined. I know I said 3 pillars, but looking at the grand scheme of things, 4 things combined, it's just not great. And aspiration pneumonia is so terrible. And it's so important for patients to understand the risk of it, especially I have younger patients in their 70s, and one guy that came in, and he really should have been on honey thick liquids. He should have been on a pureed diet, but he did not care about it. He wanted to eat what he wanted to eat. On the swallow study, it showed that he was silently aspirating. He's like, I don't feel anything when the food goes down. I'm like, that's because you're silently aspirating. I said, you're at risk for getting aspiration pneumonia. Come to find out, it wasn't even the first time that he had aspiration pneumonia, but he had survived the past 2 or 3 times. So he thought it was going to be fine. And unfortunately, by the end of that week, despite my recommendation and me going back and forth with him about it, he died in the hospital. So it is so important. It is life or death. And there is a big awareness that needs to continue to occur about it, because I feel like people don't know about it until it happens to them. And we want to prevent it from getting to that point, so knowledge is wealth, as people say.
Yeah, 100% agree. And, so on one end, we have the patient's actual, say, maybe they have the mental capacity to be able to, make these decision choices, but they don't have the physical ability to do so. Now, let's look on the other spectrum where the patient doesn't necessarily have the mental capacity to make these decisions. And then you have these family members who are like, who are in a scenario where they're like, you have your recommendations, yet they're saying, oh, well, my loved one actually really likes this when I feed it to them. So as you were discussing this with me, one of the big questions that came up is, how can we tell a couple different things? One, from a flavor or food perspective, a question that comes to mind is, how can we actually determine, is it an actual reflex, a reflex of whatever they're putting in their mouth versus them actually enjoying it? And the second part is, what are things that family members or loved ones need to understand in order for their loved ones to live longer and avoid something like aspiration pneumonia?
That is a really good question. So to answer the first part of it, how do you know if something is a reflex, where if you put something in the mouth, they're just going to eat it anyway, versus them actually enjoying it? Sometimes it has to do with background information. If Pop always liked chocolate milkshakes and cheeseburgers, and then he still likes it, that's fine. But the thing is, at the end of the day, you have to educate the family and tell them, if you're going to feed them this, you need to know the risk that you can possibly kill Pop. Do you want that to happen? Is that something you're okay with carrying the heavy weight of? So I do have some families sometimes, when it is people that are older, or they just have a poor quality of life and they just want them to go in hospice and be done anyway. That's when it is more of like quality of life thing. But when it is a patient that has the rehab potential, that if I do swallowing exercises with them and they will improve back, I will tell them, look, it's going to be a slow process, but we can eventually get them back to that. Let's use that to motivate them. But how do you know if someone is really enjoying a food versus a reflex? That is a good question. Usually those patients, they'll at least kind of perk up when it's something that they really enjoy. If it's not, they'll keep their eyes closed and they'll just keep chewing and eating. That's the one thing I've noticed. When a patient is given a pureed blueberry pie, pureed chocolate cake or something, or even a Magic Cup, which is the safe IDSI level 4 version of ice cream because it doesn't melt, to like the thin liquid consistency, you will see them perk up a little bit. So that's what I've noticed when you really truly know that a patient actually enjoys that versus they're just eating because they're used to food being popped in their mouth and they chew and swallow.
Very cool. Thank you so much for sharing that, because I was just wondering, about that, because reflexes, listeners, are things that happen that are just like kind of deeply rooted into our brainstem, and there's some sort of mechanical stimulus, and then there's some sort of physical reaction to that. And I do appreciate you saying when the patient perks up, when they open their eyes, they get a little bit more active because of said food. It's always really cool. And I know that especially when I see, one of the things that I really enjoy is watching people's first bite of any food that they actually really enjoy. Like, you truly see that there's like a whole reaction to their body when they eat something. They're like, wow, this is delicious. So very, very cool. So let's talk about some of the things that you actually do in a seminar like that, from feeding analysis or feeding training, because I know that whenever I see something, I'm just like, oh, what are you doing there? So tell us a couple of the tools or techniques that you actually use to actually help train patients back into eating and building up those muscles.
Sure. No problem. So there's a few things that you can do. Sometimes the base of your tongue, which, believe it or not, is not literally, when you look at your tongue, that's not the bottom of your tongue. The base of your tongue is actually a little bit down your throat. There's something called lingual strengthening against resistance exercises. You can do this with a plastic spoon or with a tongue depressor. And what you're going to do, just how a naughty kid sticks out their tongue at you when they're being rude, you're going to do the same thing and push either a tongue depressor or a plastic spoon away from your mouth and then retract your tongue. And the thing is, for my listeners, please don't just be doing this at home with your family that has some swallowing issues. You need to actually do a swallow study to know that they have a weak base of tongue. But even if you have to train that patient to know how much resistance to be giving the spoon, because you have to be pushing against the tongue a little bit when they're trying to actually push against the spoon or the tongue depressor. And over time, that strengthens the base of tongue. I love when I hear patients say, ooh, the bottom of my tongue, but it feels like it's down my throat's a little bit sore. And I'm like, good, you're exercising the right muscle. So you have that. You have chin tuck or chin tuck against resistance. So the chin tuck is something that I hear a lot of people say all the time, oh, you're having trouble swallowing, just put your chin down when you swallow, which, yes, but it does not always work. I love to know that people know that, but then sometimes I do roll my eyes because I'm like, it doesn't always work, But chin tuck against resistance, what that is you will take, it can be a couple towels rolled over and folded underneath your chin. It can be a small little silicone ball. I just got this thing. It's called a neck toning thing. It's on Amazon for like $10. And what you're doing, you're pressing your chin down onto that. And what that's doing, that's strengthening the muscles inside of your neck that have to do with swallowing. Because you want those stronger when you're trying to swallow. You have your effortful swallow, which is when people tell you to swallow hard and fast. I get a lot of weird looks when people are like, what do you mean swallow hard and fast? So what I tell them is, pretend you have a big horse pill that you're trying to swallow. Are you going to just do the cute little sip that you do with your tea? Or are you going to be swallowing nice and hard to make sure you push that thing down? So usually when I tell them that, that's when they understand, oh, okay, I really got to make sure force it down. My favorite is respiratory muscular strength training. So there's this tool, it's called a breather. It's pricey, it's like $50, but it targets both inspiratory muscles and expiratory muscles. And what that does, that's strengthening your airway protection because it strengthens your vocal folds, keeps them nice and closed. So you're reducing risk for aspiration. It's going to also help with clearance. If you do have any penetration occurring, remember, penetration is when solids or liquids are above the vocal folds. So it helps to do all that stuff. Plus, for my patients that are sometimes on oxygen and also have swallowing problems, it also helps reduce shortness of breath and improve respiratory health. So it does also all sorts of amazing things. I love it. It's my favorite thing to do. You have your head tilt. That's for patients that have, which I didn't really talk about, but sometimes you have patients that have poor lip seal, that the foods and the solids just leak right back out. You want to tilt your head back, and that helps with the food going down the right way. Plus, remember, your windpipe, your trachea is in the front. So if you're tilting your head back, it's automatically going to try with gravity to go straight to your esophagus instead of to your throat area. And there's so many more things that I could talk about, but those are the main three that I like to do. one thing that I think is really cool is the McNeil dysphagia therapy program. It's not something I'm trained in yet, but it's like one of my goals is to get certified in that. This is for patients that have laryngeal cancer, that had a laryngectomy. And so now they really need to relearn how to swallow. And you'll be surprised how many people miss bread, because that's like the hardest thing for people to get back to. Bread requires so much saliva, so much chewing effort and everything. So it's basically how I believe you start at the bottom with simple things like pudding and applesauce and stuff like that, and have the patient work their way up. And I don't know all the entirety of it. I've only ever watched one of my supervisors do it with a patient, but it is really cool. So it is something that I do think people should really be more aware of, is that there are these other tools and other mechanisms out there. But those are my main go-tos, but there's so much more I could get into.
That's so fascinating. Thank you so much for sharing. I'm thrilled to hear that you actually recommend chin, or usually also implement chin tucks into your treatment plan. Interesting enough, in the physical therapy world, I actually use chin tucks to actually help people when it comes to neck and shoulder pain. And to be able to hear that, you'll be able to strengthen, for you, it's really more like the deep neck flexors and also the deep, the muscles that are involved with swallowing. Mm-hmm. For the orthopedic standpoint, we're actually work on the deep cervical flexors, which actually are very important in regards to stabilizing the neck. So it's cool to see the parallels, which is very, very cool. This is all really important stuff. I think a lot of people, especially when they do have a loved one who is in the rehab setting and does require work from you, it's important for them to know this information, so then that way they can be educated and understand why their loved one is not eating the Five Guys burger that they always loved. But then I also really appreciate that you said, we have to look at what's the quality of life in regards to that as well. So being able to measure, and you're looking at these patients as human beings, mm-hmm. not just, okay, this patient has I don't know how you rate muscle strength, but it's like this patient has like a 4 out of 5 swallowing ability. We need to do this, this, and this. It's really more so, okay, here's Mr. Jones. He has this weakness, but like this is the scenario. And I really appreciate you sharing in regards to like the rehab potential as well, because there are some folks who are going to have the permanent changes from whatever event that they experience, but there are folks who are actually able to have that rehab potential and be able to say, hey, listen, there is going to be an opportunity for them to eat it, just not right now. So let's talk about some action steps, right? So you shared some really great techniques, and we talked about the importance of ensuring that our patients or our loved ones don't aspirate on food or liquids. For the listeners who have a loved one who might need an SOP like yourself in the setting that you're in, what are some of the qualities or things that they should have or need in order to start working with an SOP? What are things that they should be looking for to ensure that their loved one is actually in the right hands?
So one thing I will always say, first and foremost, a quality that any person should have is patience. Things are going to take time. It's not going to happen overnight. I have a lot of patients, they come there on period and they're like, I want my diet changed today. And I'm like, well, in order for me to upgrade you, I'm going to do a swallow study. And that takes sometimes a while to get scheduled. So patience is so important. Sometimes we think that, swallowing, I eat every day. It's no problem for me. Why is it so hard for them? Things take time. The body needs time to rehabilitate, especially when you're an elderly person. Your body does not snap back the way it used to when you were in your 20s, 30s, and 40s. And, you do see that decline in your ability to rehab quickly. So that is one thing that people need to have as patience. Another thing is realistic goals. You want to be optimistic, but you also want to be realistic in what your expectations are. And this is not to come from a morbid standpoint, like, your grandpa, your father's never going to be eating what he used to eat. But it's just sometimes, while there can be great rehab potential, sometimes if the patient's not willing, if they're not motivated, or if they just can't get the strategies or exercises down to where they can make that progress, unfortunately, sometimes they're not going to progress back to the food they want to eat. And that's something you're going to possibly have to be okay with. some things I always would like for patients to look for in a speech therapist to make sure that they are someone that is going to take care of their patients. Ask them what their plan of care is. Ask them what exercises they're going to implement, if any. When are they hoping, when should they expect progress to happen? Sometimes we don't know. Each patient's different. If you see a patient with dysphagia, you've seen one patient with dysphagia. Sometimes I have a patient and I look at them and I'm like, man, I don't know. And then they surprise me out of nowhere. They perk up. They're back to their normal selves. Sometimes it just takes stability. You know, when these patients with strokes or TBIs are in the hospital for like 2 to 3 weeks at a time, they're so wiped out. But when they come to the SNF, they've stabilized. They're getting their medication. They're getting like really good care. So they perk right up. But things to look for in a speech therapist, like I said, make sure you're asking them about their plan of care, what exercises they're going to be doing with them. How often are you going to be collaborating with other people? They should be able to give you answers for these things. And then ask them what diet they're currently on. They should know before they step into the room what diet your patient's on if they're seeing them for dysphagia. It doesn't take long to do a quick chart review, log into whatever EHR you're using and see really quick that the patient's on mechanical soft or they're on pureed or they're on honey thick liquids. So those are all things to be aware of. And then definitely keep the speech therapist accountable. Make sure your patient doesn't fall through the crack. They usually don't, but you know, it happens. It hasn't happened with me, but it just happened. So just make sure you stay on top of them in a loving and patient way, of course, because speech therapists, sometimes you might not be the only swallowing patient we have. There might be other patients that we're also seeing for meals. I believe this past 2 weeks, I've had 2 patients that eat at the same time. So unfortunately, I can't be with both patients to eat. One's on the 6th floor, one's on the 3rd floor. That's not realistic. I can't be in 2 places at the same time. So what I do is some days I'll go with the patient and I will just do their exercises with them and then give them a snack of the same consistency that they're currently on, along with a liquid with the consistency they're currently on, and work with them that way. And then my next patient, I will actually see during the meal and implement strategies, and I'll provide education to both. So making sure that your speech therapist really has the patient's best interest at heart and is being consistent in the therapy flow of things. If they're saying they're going to do this by certain time, check back in with them. But again, we have to understand that, you know, we know that our families mean well. We do have how we have helicopter parents, we have helicopter children. So there are those children, and I get it. I'm an only child and I love my parents dearly, but at the same time, have a little grace with your speech therapist. They're doing the best they can, but definitely try to check in with them now and again, just making sure that things go well. Sometimes things change, sometimes for the better, unfortunately, sometimes for the worse. So that's my advice to loved ones.
Yeah, really insightful and really helpful in regards to just trying to better navigate this world. You know, no one ever chooses to be in the rehabilitative setting as a patient. No one ever wants to be into that, but it is important for us to know, you know, what's available to us and how to actually maximize the effect, especially, you know, if you are a loved one, you have someone you care about who's living in a setting like this, how can we better, you know, serve and support them so they can recover, or if they are in fact in their last days, how can we actually maximize that time that we have together? So really, really insightful, Kathie-Lee. Very, very cool. I have only met a handful of SLPs in my day just because of the setting that I work in, but huge value in everything that you provide. And I'm thankful for the work that you do. And thank you for your time today, being able to share the work and expertise of an SLP, and especially on the feeding standpoint. I think it's a very important piece. So, I mean, for the listeners out there who have, say, questions or want to know a little bit more, is there a way for them to get in touch with you to, you know, send you any questions?
Yeah, sure. My email, which is kathieleejp@gmail.com. So that's KATHIELEE, J as in John, P as in Paul, @gmail.com. That's my personal email. My phone's always on me. It has to be. I'm I'm a type 1 diabetic, so I'm always checking my phone for my sugar levels. So I answer emails pretty quickly. If there's ever any questions, you just want advice now, I can't tell you what to do. And please do not take what I say and be like, well, this speech therapist said this. I don't know everything about the patient. I can only give suggestions. So just fair warning on that. And also, please don't go against whatever the speech therapist recommends for diets. That's my last piece of advice.
Absolutely. Listeners, the email will be in the show notes, but yes, absolutely. Everything that we're sharing with you is really more so as information and education. Any of this stuff does not replace the advice from your medical team. And so, I say it at the end of each episode, but definitely be clear. And I really appreciate that, Kathie-Lee.
Yeah.
No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.